This is the balloon itself here at the end, which we'll see more of later, but it comes with other pieces of equipment. This is a very stiff guide wire which will help the balloon pass into the left atrium, and this is, as we'll see later, a stiffening tube which will make this balloon longer and stiffer to help it get through the skin and the atrial septum, because this is a very safe balloon. It's nice and soft and floppy, but that would never go through the skin or the septum. And this straightening tube will alter it temporarily to allow it to do that. And then finally, there is this special stylet which helps to guide the balloon around the corner and through the mitral valve. And the last piece of the equipment is the dilator. This will open up the hole in the atrial septum to allow this somewhat thicker balloon to pass through. Now we have to prepare the balloon, and we first of all give a flush through to get rid of any bubbles which may be within the inner part of the balloon catheter. And now we've got to prepare some altered contrast. And this is a special syringe which is used to dilate the balloon, and it's marked off in different sizes. As we'll see, this can affect the size that the balloon is dilated to. But I'll just show you the special dilatation characteristics here. The balloon is designed so that when you first inject contrast, it's the distal end that inflates, allowing you to pull it back and up against the valve. And then the proximal end dilates to hold it in position. And then finally, that middle section, it can vary in its diameter according to how much contrast you inject in. We'll give a flush. And you'll see here, as we push the straightening tube up to the end of the balloon, it changes to be much slimmer, now much stiffer, and this will allow us to push it through the skin and the atrial septum.
Feeling sleepy now? That's great.
So we go on and look at the commissures. Now, the posteromedial commissure is best seen at around 90 or 100 degrees in a vertical kind of plane, and we're just rotating the whole probe medially until we see the two leaflets fused together. So anterior and posterior leaflet are fused together here. We can zoom in and get a nice view of the leaflets. And for us rotate medially again, you can see when the leaflets are fused together, this area where they're fused is the posteromedial commissure, the fused part of the posteromedial commissure. And there's no calcification actually in that commissure. We can assess how extensively it's fused just by rotating the probe over to the annulus there, the medial annulus, and then coming back from the annulus. We're now on the leaflets, and then we just keep going until we see the valve open. And there's extensive fusion of that medial commissure, and I think that looks quite nice to split open. There's actually also quite a good view for looking at the subvalve apparatus. We can see the posteromedial papillary muscle there, and these cords are thickened and there's some fibrosis, but for someone with such a long history, actually the subvalve change is not too bad here. The other thing we can do if we have a second is just to assess the hemodynamics of the valve. So we can measure the valve area by pressure half time. So to do that, a little bit more depth. To do that, just check you're in line with the flow through the valve. First of all, obviously, all Doppler, you need to be in line with flow, and that's pretty good. I'm just withdrawing the probe up to a slightly higher esophageal level to get that alignment. And see, because we're nicely aligned, we've got really nice Doppler traces here. Now they're slightly curvy, and it's difficult in this situation to use the pressure half time, but will give us an idea of the valve area. We get 1.2 on that one. We were getting a valve area of about 1 centimeter squared earlier, just over 1 on that. So we've averaged a few, and we got about 1.1 as an average. So it's kind of moderate to severe, this stenosis, and we think the regurgitation is mild. And if you want to quantitate this, we need to freeze it in early diastole. Like, it's probably not ideal, but just as an illustration, we can go into 3DQ, and we need to set this up. I'm just going to do this very quickly, but and you know, when you're doing this on transthoracic echo, you don't always know that you're in the plane of the valve. The great advantage of 3D is obviously you can move these around. So as I move this up and down, I'm sure I'm in the plane of the valve. And as Peter says, if we're a little bit high, this is exaggerating it obviously, but if we're a little bit high, we can see a huge valve area, and clearly that's through the body of the leaflets where the anterior leaflet's bowing, and you've got to make sure that you're down at the tips of the leaflet. So we would measure roughly at that kind of level. And that's a typical kind of narrow slit-like orifice that you'd expect in an older person with mitral stenosis. Be a little bit more circular in a young person with very pliable, non-calcified leaflets. We're going to minimize the radiation and the contrast here. I think that's the point of the TOE. So we've turned the frame rate down as far as it can go. We do that for all the structural cases. In fact, we're doing that for everything. So it's just 7.5 frames a second now for all the structural cases where there can be quite a bit of screening. And we're going to use Fluorostore rather than acquisitions, again, to minimize the radiation. Much more relevant in younger patients, but it's very relevant for the staff and everybody else as well. So the radiation dose in these procedures with modern equipment can be very low.
Take the needle down.
Okay, the wire's out. Can you get rid of that?
Now the needle at the moment is just inside the catheter, and I'm rotating it so that the arrow is pointing to about 5 o'clock, starting to come down. There's a possible little jump there. How does that look on TOE?
So when Stuart presses on the needle, we should be able to see tenting on the atrial septum. And Alan will just rotate. He's just going to move the probe from side to side. I think you've actually just starting. If you press a little more firmly, Stuart, we can see tenting nicely there. Very happy for you to go through there.
Okay.
You're quite high in the septum, but it's fine. It's fine though. Are we through?
That's the needle through now.
So you can see the tip of the balloon very close to the orifice, and it's through. We'll go for it now. Okay, Stuart, just over to you. Coming up distally.
Yep, all the way.
And down. Okay.
There's no real change in the left atrial pressure.
I didn't see the balloon waist really give then.
No.
And there's no change in the regurgitation.
So this is 24 millimetres now.
Yeah. Echo image there, you can see the balloon tip coming down to the valve. Just about to cross. There it's across. So you ready, Stuart?
Okay.
Up distal.
Pull back.
And all the way. And down. Okay, if we can store that again, Mark. So we've maybe gone from 1.1 to 1.3. I mean, it is a palliative procedure and we're going to be cautious here, but I think another millimetre, Stuart?
This is 25, yeah.
25, going up distally.
Just yeah.
And all the way.
Oh, we gave a wee bit at the end there. Seen the upper bit.
And then down. Okay.
Store?
And then stop screening
Can we
and we'll store.
store that, Morag? As the balloon dilated, just at the end of the dilatation, there was a sudden movement, which I think corresponds to that commissure opening. So I don't think there'd be anything to gain from going higher when that was the only bit that was able to open. And we'd run the risk of reflux, unnecessary reflux.
So I think we've done it. I think we've done exactly what we thought. We've got exactly the kind of benefit we thought we would get. And if we just flex and pull back a little bit, we can see the anterolateral commissure. And I don't think there's been much change here. This is the fused and calcified commissure that we didn't expect to open up. We might have opened it up a little bit to that point, but at this point where it's calcified, because you can see right next to it, if I go down just right next to the calcification, it has opened up. So I don't know. If anything, it's been a very marginal improvement on the anterolateral side of the valve. But if we look at the medial commissure, the posteromedial commissure now, so this is where the valve is opening and I can rotate medially into the commissure. There is still a fused bit, but it's much shorter. So as soon as I keep rotating, we're at the annulus. I'll show you again. If I come back, we're at the annulus, come back onto the valve. So that's the residual fusion just next to the annulus. But as soon as I come back a little bit more, the valve opens. So this commissure has opened up. There's minimal residual fusion at the medial commissure. But the anterolateral one's still fused, which is what we would have expected. So we can swing around to long axis view, or a 3-chamber view is the best view to look at that regurgitation. There's 2 jets really. There's this early systolic jet, which is quite central, and then there's this one that's more posteriorly directed. Both of these were present at the start, and we measured the PISA. It was about 4 millimeters at the start, and it's still about 4 millimeters if we reduce the color velocity. So it's mild to moderate regurgitation at most. We haven't been anywhere near the aortic valve prosthesis. It's still working fine. So always nice to get a 3D view if we can. So it's a nice view from the atrial side. This is the posteromedial commissure on this side. I think we can see that you've opened up that medial commissure on this side. We can swing it around and look from the below. So yeah, so this is the medial commissure that's opened up a bit, the anterolateral commissure. You can't really see calcium here. You can kind of fool yourself, but you can't really see calcification on the 3D image. But we can take that into 3DQ and measure a valve area offline at the end. I think that's as much as I can give you from the echo. Okay.